are in lovely Los Angeles. But when we think about hot weather, we can think back many, many years ago. Epidemics, pandemics, diseases that spread quickly. A lot of times we don't know the cause or the source, and they are often out of control. These are things that used to happen before we had modern day medications and antibiotics. And with things like the bubonic plague or, different things that happened in different parts of the world, those things seem to go away with modern sterilization, clean water, and different habits. However, we got surprised in 1981 when we had our own epidemic or plague or pandemic, whatever you want to terminalize that. And so because of that, it gave us a new appreciation for healthful practices and development of medication and all those things. So we remember that time. It was devastating for many people, and it took a while for cures to develop. But now things seem to be under control. That's really the problem. It's become so commonplace and so controllable, there's some people that aren't paying it close enough attention. And what we've found is there's some diseases that kind of cooperate with it, like hepatitis, which is a disease of the liver. So I have an amazing guest today, Dr. Orlando Pyle. This is a gentleman that has devoted many years to the care of patients with HIV, AIDS, and other diseases. But that's really been a primary focus for him, I would say, especially here of late in later years. And so he's going to first tell us a little bit about himself, his trajectory into getting into this field, and then we're going to talk a little bit about some details and try to bring some of these issues to the fore. We don't need to sleep on this. We need to stay focused on this and make sure that we're using healthful practices that don't allow us to contract it. So welcome, Dr. Pyle. I'm so glad you're here today.
No, I'm glad to be here also.
This is a gentleman with plenty of energy and verve. He speaks all over the country, he travels all over the place. So this is a lot of great experience we have here. But I want to know, do you remember the first time you heard HIV/AIDS? Where were you? What were you doing? Were you in school? Were you finished with school? Were you practicing?
No, I was not in school. I finished medical school in '76.
Okay, so he's telling his age. I didn't make him, okay? So that, he volunteered that.
Yeah. In '76 at Martin Luther King Hospital at Charles Drew. And then I went into, I was doing urgent care, and then eventually I went into private practice. Only because a doctor had a stroke and they asked me to cover for that doctor. So I did that a couple of days, and the other times I was doing nursing homes, etc. Okay. And eventually I left there, started my own practice in Inglewood, California.
Nice.
And that was in 1980. So I've been in Inglewood ever since then, and I'm in my present location since '86. Now, primarily internal medicine. So in 1985, I was speaking to a buddy of mine, Dr. Marvin Ross, and it was in December, and he called me up one night, and I'm late at my office, and he says, I asked him, where are you? He says, I'm in the jail. And I'm like, what are you doing in jail? He says,
are you in jail, or are you just in the jail?
I'm on call at the jail, and okay. I said, well, you take care of the deputies? He said, no, the inmates. So I said, you know what, well, do they have any part-time positions there? And he said, yeah, they do. So
Wait a minute. What made you interested in working in why did you want to do that?
Because at that particular time, my practice started getting a little bit slow. And then I was working a lot more hours to go into different hospitals or whatever. And I was like, and just before that, my accountant told me, you need to maybe get rid of the practice and then go into work for the county or something like that. But it just so happens that I said, when I was a little boy, my dream was always to become a doctor and to have it in a house. And God has always
like in
said,
a house.
A house.
Okay.
Because my physician back in Brooklyn, his apartment was his practice area.
Notice he threw the Brooklyn out, you guys, Give it up for New York.
Yeah, but what
I trained there, by the way, so I love it.
So I decided, I said, listen, I had prayed on it, and I told my accountant, God is not going to disappoint me. And so therefore, I'm not going to leave my practice and my patients.
Okay.
But it just so happened, I get this call from Marvin Ross. So I called the jail, the county jail, and they sent me an application. And eventually I interviewed there.
Yeah.
And Dr. John Clark, who was the chief physician there, hired me. And in May '86, I started working part-time for the county jail.
So was that perfect? Did you satisfy your accountant?
Yes, I did, and only because what happens is that I did that like 2 days a week, and I still had my private practice.
So was it in the jail that you heard of HIV? Is that when it happened?
Yes, I heard about it just before becoming part of the jail.
And what did you hear? Like, what was the thing that you heard? Do you remember?
Just hearing it more in terms of gay men, particularly like Rock Hudson, coming down with it, and the boys in the band. When you heard about that movie that came out, and that was a lot about it.
Yeah.
So what happened was, I started working at the jail.
Yeah.
And then
Were you interested in HIV at that time, or you just had heard it?
No,
wasn't really
I was
you
not.
were just trying to get into a good gig.
Well, yes, I was just pay the bills.
You gotta get in a good gig.
So what happened?
It's tough out here for us. I want you all to know that, okay? In medicine,
Yes,
reimbursements, insurance, and things like that. So when you're in
Exactly.
private practice, it's not a piece of cake, okay? So be good to your physicians and pay cash. So go.
That's right. Take care of your physicians.
Take care of your physicians.
Yeah.
They have student loans.
So here I am. I'm working in there, and about within 2 years, the person ahead of the TB unit at the county jail retired. So Dr. Clark asked me, would you take over the TB unit?
As in tuberculosis.
As in tuberculosis.
Wow.
So I said, now at King Hospital as a resident, we saw TB every day.
Yeah.
Every day.
At that time.
So, and took care of all of them. And resistant TB cases.
Yeah.
So I just said, sure, I'll do it.
Yeah.
So here I am taking care of the tuberculosis patients at the county jail. And then all of a sudden I had these group of patients that just did not get well. And the sputum said, no, they were susceptible to all the medications. But they weren't getting better. And they were becoming anemic and everything. And those were AIDS patients.
Wow.
So it just so happens that I had to, Dr. Clark told me, he says, you got to learn everything about HIV. So he sent me all over the place. I went to USC, I trained at USC, I went to Palo Alto with Dr. Andrew Saloper, and I learned about resistance, and Dr. Peter Verwain at Cedars-Sinai, Gay and Lesbian Center, women's care, women's child care.
How long did all of this take you? You know, was this?
Well, the training was like over about 3 months. You know.
Wow, that's intense.
Yes, it was about 3 months. So there was times that I was like maybe in a classroom setting, maybe for like 2 weeks or a week. Then I would go back to the jail, and then I would go part-time over here and here and there. So eventually, here I am now taking care of HIV patients. So the only medication was AZT. But it was at 2,400 milligrams. Now, the present dose is 600. So there's 4 times that. Well, you saw every type of reaction that you're going to have with AZT.
Because it was intense therapy.
Right. And AZT was an anti-cancer drug. But what happens, the reason why they stopped it years before is because they caused severe anemia.
Oh, I see.
So now with these patients, I noticed that their nails turned black. Their skin was dry. They had diarrhea. Their hair was falling out and everything. And then finally, I just said, you know, I'm not going to give them this. So I made up a protocol of nutrition. And I found that I needed to stop the diarrhea. I needed to make them gain weight.
That's right.
And once I developed this protocol for it, and with multiple vitamins and everything, and then all of a sudden these patients started stabilizing.
So how did you develop the protocol? I mean, is it something that you said, well, let me just take a group of patients and I'm going to try out this on this group and this on that group? Was it part of the training that you did? Where did the protocol come from?
Came from my mother. Because my
Dr.
mother,
Mom,
see, my mother and father, they're from Guyana in South America. Okay. And what happened is that she always talked about her father, who was a chemist, he was a pharmacist, he was everything over there.
Right.
And he used to vaccinate everybody. But she always talked about herbs and the things that you did to take care of people.
Right.
So she did it with us. I'm one of 11. So she took care of all of us with these herbs and everything.
But herbs are the same, to me, herbs are the same as medication. I mean, that's where medication comes from. It comes from, you know, natural things, but it's just taken into the lab and it's reformulated into something that's more synthetic. But that's the basis of all of these things. Penicillin and all that stuff came from something.
But it was not only just, my mother's herbs were like garlic, lemons, for breaking fever, clove tea to stop cramping from diarrhea, all of these other things.
So you remembered all of that?
Oh, absolutely.
Had she written it down? Was there like a book or anything? So
no, but as many times when you have 11 kids, as many times we've gotten sick. So you know what is coming. Like you start getting sick and you go, here comes the enema, and we're gonna get an enema. Okay, here goes this.
What kind of enema? What was she putting in that?
Oh, it's just basically warm water. You put it in that bag, and to have you lie on your side right through the rectum.
And she would do that?
My mother did all of that.
For what kinds of issues?
Oh, fever. You had a fever, or you had abdominal pain. You had diarrhea. Cleansing. It was cleansing, and then she would give you like soups, non-fat soups. You would have like dry toast and everything.
Okay, so where's the book? This is amazing.
No, Mom, there was nothing about it. It was just her
your book.
growing. Oh,
come on!
This
is incredible.
Yeah, but the thing is that with the patients, I realized that you had to make sure you had to give them something. First of all, they were losing weight.
Sure, and that's really the biggest problem almost with any illness is losing a lot of weight too quickly.
Now, in addition to that, there were certain things that I got involved with outside of the jail, which was with nutraceuticals like Tahitian noni juice and different types of herbs, and with Dr. Nathan Rabb and myself, who's a holistic naturopath.
Nice.
So we worked a lot together in terms of with this different formulas and different herbs and everything else.
But
and
how
I
did you do
incorporate
that in the jail?
I didn't do it. I couldn't use it in the jail.
Yeah.
But everything else that was part of that, in terms of the other nutraceuticals, it was diet. So I had to get away from foods that would basically cause them some problem with their GI. So I gave them less meat. I tried to give them as much nutrients and calories, like Ensure.
Could you control that
in
the jail?
Yes, I could, because I could write that protocol, and within the jail, they had Ensure. So I could use that. Now the only problem I had with Ensure with people were lactose intolerant. So I had to use something else.
They didn't have Clear at that time. Now they have Ensure Clear.
So what I would try to, and I created a shake. Okay. So I had a milkshake type of thing.
You're kidding?
Yeah, so I created a milkshake and gave them these shakes. So I worked with the dietary department.
This is blowing my mind because I can't believe they allowed you to do this, because that's pretty groundbreaking at that time. Was it a battle to try to be able to provide this, or was it something that they were open to?
Actually, they weren't, because they had for patients that were either having starvations or they were not tolerating certain meals and they were losing weight. So they created these shakes for them. So what happens is that I just kind of tweaked them a little bit, and that with multivitamins, vitamin C, and cimetidine, which was also had something to do help with the immune system. So I incorporated all of this, and I began to stabilize them. And at this point, we're talking about in the late 80s, early 90s, now we're seeing patients now the pharmaceutical companies are creating the nucleosides and then non-nucleosides. So now we're coming with medications that we can treat and stop the replication of the virus.
Right.
So this is the whole key thing. The key thing is, how do you get control of this virus, which basically attacks the immune system.
Absolutely. And the immune system is the basis of everything. I mean, all we do in medicine, and I try to explain this to my cancer patients, all we do in medicine is we prepare the body to fight, or we give it a head start. If I cut out a cancer, even though that's considered a cure, it's really just giving your body a head start on going after all the other little cells that we can't detect, because we don't have 100% detection in medicine, right? It's only what we can see, only what we can study with labs or with imaging. So that's the beauty of it. So for those of you who are just joining us, we're with Dr. Orlando Pyle. We're talking about HIV and also hepatitis, and I want to jump into kind of the current day and what's happening now. It seems like people have kind of relaxed about HIV and AIDS. They've gotten to a point where people don't, it's not so much of a big deal, and nobody's frightened or anything like that. Do you think that type of attitude is contributing to any resurgences or anything like that? What are you seeing in the community?
All of that.
Yeah.
All of that. There's a false sense of security that has developed. And the reason why is because the medication is so potent and has less side effects that people can take the medication, reduce their viral load to undetectable, raise their CD4 count up. The only problem is people are living longer now.
Yeah.
So now you have all these comorbidities in terms of other type of illnesses. Hypertension,
Right.
High cholesterol,
Comorbidities are just other diseases.
other diseases,
Yeah.
diabetes,
Yeah.
elevated blood sugar, kidney, renal problems. So now you have people who are now not 20 and 30, but now you got people 50, 60 years old. And
Which is a victory in a lot of ways.
Yes, but the most alarming thing is some of the highest or the largest number of new HIV diagnoses is over the age of 50.
Right. Right. And, you know, I have a friend who works in Atlanta, and I won't mention the hospital and everything, but got a big grant to do this long longitudinal study. And what they did was they tested every patient that came into the emergency department in one of the big hospitals there. They tested them for HIV and hepatitis. And what they saw is a surge in HIV at age 50 for women of color. And, of course, that coincides with menopause. And now, like, hey, I'm not having my period anymore, unprotected sex, this is awesome. And so even if they had a long-term partner, you know, some of them would develop HIV as a result of that. What do you say about addressing that?
Okay, so the first thing that's important is that everybody needs to be tested.
Yeah.
Okay, so if you
Everybody needs to be tested.
everybody needs to be tested for HIV and hepatitis.
Everybody in the world.
Everybody.
Okay.
Because HIV, they've got cases as young as 15, 13 years old. So you got teenagers who are having sex, or if they're not having sex, they're having tattoos with non-sterilized needles.
I'm so glad you're mentioning this. The tattoo is not necessarily
and
benign.
piercing. And the same piercing. So if you don't cleanse these tools that you're using to pierce, and somebody else's blood is contaminated with HIV or hepatitis, then therefore you can pass this on to the next person. But the point is that especially these patients that are over the age of 50, now you have women who are having sex maybe with one partner,
Right.
but that one partner may be having sex with more than one partner.
Or did in the past, and they've been carrying it along. They don't know that
and
they
never
have
got
it,
tested.
Or maybe they do know, but
That's
they just
right.
couldn't really see
And they're
it.
transmitting either hepatitis or HIV. More likely they're transmitting
Hepatitis.
HIV.
HIV than hepatitis.
Than
Okay.
hepatitis, because hepatitis is predominantly more than 90%, 88% through needles, contaminated needles,
Right.
or no longer blood transfusions. They
clean that up.
They clean that up.
Yeah.
Okay. So now, and then you have men who are having sex with a lot of women who are maybe not only have STDs, such as chlamydia, gonorrhea, or even syphilis, which is on a surge now. Syphilis is coming back, and this is because of unprotected sex. So what happens is that they've developed to say, well, okay, what do we do? Okay, condoms, yes, you have to have protection and everything, but people don't use condoms.
Right.
Especially in the community of the men having sex with men, a lot of times they'll have multiple sex partners. So now they've come across with the PrEP, pre-exposure prophylaxis medication of Truvada. There's this combination which they will take this. Now there's two ways.
The men will take it.
The men or women.
Okay.
Okay, so they have it on a daily basis, you take it, and it prevents the transmission of HIV.
How long do you have to take it?
Well, now they say this is the whole thing. As long as you're having unprotected sex, you need to take it once a day.
So here's the thing. Let's go through some scenarios. I know this is
Yep.
funny, but so let's say that you are having unprotected sex, right? And then the last time that you do it is today. Do I need to take it tomorrow, next week, or am I done if I take it today?
All right. So in that case, the first thing you want to know is that is the person you had sex with, are they positive in any way, shape, or form?
But you don't know. I mean, you're doing this as a preventive, right?
If you don't know and you're not, and you haven't been
tested or anything, you don't take this.
and you haven't gone to your personal doctor, your provider,
Right.
and they haven't given you the PrEP or the Truvada,
Okay.
then therefore you can take it, but it's like being exposed an unknown exposure to HIV. It's the same thing as like working and have an occupational exposure with a needle stick or something like that.
So this is,
But that's different.
Yeah.
Because that, if you don't know whether the person is positive,
Right.
you have to actually take a course of anti-HIV medicine,
Right.
antiretroviral therapy, which would consist of 3 different medications.
So the PrEP doesn't work for those people.
No, that PrEP is not. Now, if you PrEP is good for this PrEP that you take daily, and it's PrEP on demand. So PrEP on demand is like if you anticipate having sex, it's 2-1-1. So it's 2 of the true before you have sex, and 1 on the day you have sex, and 1 the day after you have sex.
Okay.
And that protects you. That's PrEP on demand.
Okay.
Now, if you have sex and then within 24 hours you're not sure whether this person was positive or not, in that case, first of all, you have to be tested, and then you can take antiretroviral therapy for 30 days.
Jeez.
And then retest it again.
You guys, is it worth it? I mean,
that's
really.
the whole point. Is it
worth it?
Right.
I mean, because come on. I mean, I know there's a lot of sexual activity and a lot of things going on. People are polyamorous now, and there's a lot of free flow with the genders and all of these things.
Yes.
And I think sometimes people think of it as, hey, this is beautiful and natural, and it's kind of like the '60s with the love move, free love and all of that kind of thing. But there's you have to pay the piper at some point, in some way or the other. And is it really worth it? Is that tattoo worth it? I mean, think about that. That's really kind of a devastating thing to get a tattoo or a piercing, and then you learn that you have something like this. It really is a devastating thing.
The other thing that's important is for providers. Providers don't ask their patients about their practices in terms of their sexual practices.
So what should we ask? What kinds of things should we as physicians ask the patients?
You can be very direct to them. I always say for all my patients that come into the office, and this is the first time I'm seeing them, I say we do a generalized blood screening. And our generalized blood screening is we check you for your diabetes, cholesterol, for thyroid, et cetera, and we check for STDs or STIs, sexual transmittable illnesses. So we check for HIV, we check for syphilis, and we check for the hepatitis A, B, and C.
Can I just ask you this question?
Yeah.
Why did we switch from STDs to STIs?
I don't know that.
Because
I think
did it
CDC,
become politically incorrect or something? And it just all of a sudden.
I think the Center of Disease Control in Atlanta, I think they may have switched it to sexual transmittable illnesses. And so I'm going, okay, fine. It doesn't make any difference.
It doesn't make a difference.
If you don't want to say STD, you want to say STI, fine. Okay. But the point is, you still got to be tested.
Exactly. Okay, let's get back to what you were saying. I just wondered about that.
Now, but then I usually say to my patients, I'm going to say, okay, in terms of your sexual practice, who do you have sex with? So, well, I'm married, I'm just with my wife, or I have my partner, and he's a male, and I'm then having sex just with him. So I'm saying, okay, are you sure that your partner is having sex only with you and nobody else? So what we need to do is just make sure we screen you, and your partner should be screened by their provider. But the other thing is, men who have sex with men, and particularly anal insertive, that then you need to also swab the rectal area for chlamydia and gonorrhea.
Ah, okay.
See? And look, make sure that there are no warts or herpetic lesions,
right.
Or even ulcers, like maybe for syphilis or chancres. So this is something that you have to do, because a lot of times doctors or providers don't touch their patients.
Yeah.
I mean, the most...
surgeons do. We do.
Oh, yeah. But you, hopefully you do, unless you were operating a little bit. But the point about it is that I had a patient that told me that they had not been touched by a provider in 10 years.
That's amazing.
It was shocking to me. And they said, you're the first person that put a stethoscope to me.
Were they like offensive or something? Was there like some bodily issue?
Nope. He said that they said that the doctor came in, or the provider came in, asked them some questions and this and that, and then finally wrote things down, and we're on the computer, and they finally said, okay, so what we're going to do is we're going to do this, so and so and so, and left.
Okay.
And they never took their clothes off, whatever. You cannot practice medicine this way.
Yeah.
And this is what's the present trend at this present time. And I'm hoping that medical schools, please teach the students. You have to get a good history,
right?
And you have to examine.
Exactly.
And I had to. People were telling me about a rash, and I said, "Well, where's that? Yeah, a foot rash." I said, "Did they tell you to take your shoes or socks?" They said, "No." I said, "Well, how do you know where the rash is?"
Like, let's take a look.
I said, "Look, take your shoes off, take your socks off. Let me see." So, my feet. I said, "I don't care about your feet. Let me look at it.
Exactly.
Let me be the judge of it."
Yeah.
And that's the way I can treat it. So, and even I had a patient of mine, a female patient, that was talking about that she had this itch and irritation around the labia, not in the labia, outside the labia. And I brought my medical assistant in and came in and then we say, okay.
As a chaperone.
Yes, and then wrap them, cover them, and then say, okay, let's see what it is. So what it was just the irritation that they have along the labia.
Yeah.
No, so I treated that, but I also made them have an appointment with the GYN doctor to take care of them. But the thing is that we need to make sure that we screen people for HIV and hepatitis. Right. Now, this is the thing about hepatitis, particularly hepatitis C, that even if they've used IV drugs one time, there's a 73% chance that they contracted hepatitis
C. That's actually mind-blowing. But, hepatitis is so much easier to contract than HIV, right? I mean...
HIV is easier to control, mostly contract, sorry.
Yeah.
Well, in terms of hepatitis C, in terms of treatment, easier. In terms of complete treatment. HIV, control. Getting the viral load undetectable.
But if someone is stuck with a needle,
yes,
what's the higher likelihood, HIV or hepatitis?
Both.
Okay.
Both of them. And HIV, the larger the bore, the more likelihood of the bore of the needle. Right.
And the smaller the bore.
Well, as long as there's some blood in there. The thing about what's good about hepatitis C is that about 20 to 60%, 20 to 50% of the people clear the virus, even though they come down with it. They clear it within about 3 to 4 or 5 months.
What does that mean, they clear?
Okay, so they got tested and it came back hepatitis C positive.
Right.
And you say, well, you just recently got tested. Now, do you remember whether you got a needle stick or did you have sex with somebody or what was it? And they'll tell you. So you say, okay, fine. So what we need to do is we need to test you again in about 3 to 6 months.
And then it's gone.
And then it's gone.
Okay.
Okay. Now, those that are not gone and they're still there, then they need to be tested and treated.
I feel like we have only scratched the surface of this topic, and we've learned so much today. I mean, this is really a big thing, and, we want to educate people so that they pursue good health practices. Be careful with tattoos and piercings and all those things. Get tested. Talk to your doctor about it. I want to thank Dr. Orlando Pyle. He's an amazing physician. If you have a chance to be treated by him or to hear him speak, avail yourself of it. This is another episode of Health from the Inside Out. I'm Dr. Cutter the Curist. We'll see you next time.